Okay, so this afternoon we're going to go through management of the high-risk pregnancy. And basically, I think where we need to start off with is defining or identifying what that high-risk pregnancy mare is. And these may be mares, definitely mares, that are older in age, that have had poor reproductive conformation that we talked about earlier, may have acute or chronic disease that we talked about earlier with regards to metabolic disease or Cushing's or laminitis. They've been potentially mares that have been exposed to either leptospirosis or virus abortion or any other disease. If they've been in hospital and have been compromised and have, say, salmonella, obviously that can be absorbed and get into the fetal placental unit. And then obviously the mare and value of the value of the mare and foal, or the mare, foal, and stallion, and how we're going to deal with that with regards to maintaining this pregnancy. In addition, mares that have had placentitis or have had fetal placental compromise are potentially at higher risk of having it again, depending on what the disease process may be. I think especially with placentitis, this is true. And then any mares that have had reproductive surgeries, cervical repairs, perineal lacerations or reconstruction, C-sections, etc., they are also potentially at a higher risk for losing their pregnancy. I wanted to just mention a recent study that I found actually very interesting that just came out from the group in Australia, taking a lot of different papers looking at the overall causes of pregnancy loss associated with the equine placenta. And I was actually really surprised to see how high equine herpes virus 1 is around the world. And while we see very little, and I think you probably see less too, just because of the vaccination protocols that we have in place. Areas in this world obviously don't. But it was interesting to see how low placentitis is down here in umbilical cord torsion. And so it starts to make you think about the rest of the world a little bit more. This was also a graph from their study that showed the areas of where most of these losses or problems occurred, whether it was late gestation. Fortunately, a lot of causes of abortion or losses is just unknown, and so it's very important to keep that in mind and try not to be frustrated when it comes back as a non-diagnosis, which unfortunately then doesn't give us much to go on. This is an old study from University of Kentucky that just shows in our area what our majority of our placenta diseases are, and of course placentitis is our number one, as opposed to in this area, my understanding is that cord torsion is more, and Mandy, thankfully, is going to talk about this in a little bit versus me, because that's not my area. So just to briefly review a few reasons to monitor the mare, in our area, it's mostly due to placentitis. We have 3 different types of placentitis. The first one is an ascending placentitis, in which we have bacteria that enter via the cervical star region, and then they progress, causing inflammation and potentially bacterial infection of the fetus. And here you can see it at the cervical star region with this line of demarcation that is kind of pathognomonic for ascending placentitis. Most of the time we'll see a vaginal discharge, or we'll see premature mammary gland development if it's a clinical case presentation, with the most common bacteria isolated being a strep zoo or an E. coli. Another form of placentitis is hematogenous route, in which the mare basically becomes infected either by equine herpes or leptospirosis or salmonella, and then that goes through the bloodstream, enters the vasculature of the placenta, and then causes abortion that way. And it presents a little different with regards to how the placenta looks, because it'll be more surrounding the vasculature areas, and this is a case of fungal placentitis, and this is a case of leptospirosis. The other thing that we have a lot of, unfortunately, is our focal mucoid placentitis, or nocardiaform placentitis. And this is, again, identified by seeing a focal area, usually at the base of the horns and the body, at the most dependent part of the uterus. And we see this really thick exudate. I kind of think of it as, it's kind of like slug slime. It's just really gooey and proliferative, and it's due to nocardiaform. Here you can see on ultrasound, we have an area of separation from the placenta transabdominally, pretty indicative of nocardiform placentitis. Another thing we can do is we can look at for umbilical cord torsions, and this is because of the excessive length, again, which Mandy will talk more about, and then ischemic necrosis, which is something that we actually don't see in the United States for a change. It's something that unlike most things, we don't have. And though here, again, I think a lot is unknown about it, but potentially maybe monitoring these mares, you can help to identify it. So how are we going to manage these high-risk pregnancies? Well, we can utilize numerous tools. I think probably the most common one that we use is ultrasound, transrectal ultrasound or transabdominal ultrasound. If we're in an area with high levels of leptospirosis, we can do leptospirosis titers, which help us identify mares pre-abortion. We can also look at fetal biophysical parameters. We can help do serum hormone levels, such as progesterone, estrogens, and then inflammatory markers such as cytokines. And then, of course, how are we going to manage these mares if we do identify them in our treatment options? So again, go back to our physical appearance like we did in our first thing. Look at the whole mare. Make sure that she is nutritionally in good shape. She doesn't have any signs of an immune problem. We don't have mammary gland development, vulva discharge. I think the number one clinical presentation that we see in these high-risk mares would be premature mammary gland development. So what we have decided, or what we have slowly progressed to over these years, is looking at these potentially high-risk mares or valuable mares or problem mares by ultrasound routinely, and we do screening ultrasound examinations probably monthly, starting about 6 to 7 months of gestation, and we can follow these mares monthly, looking for any early abnormal signs, and then identifying those signs and potentially treating according to what we see. And I think one of the biggest things that we find is when we've started to do this, we may not be able to recognize what is abnormal, but we recognize that it's not normal. And so I think that's the fundamental basis, is to recognize when something is not normal. Then you can figure out what is abnormal about it and potentially treat it. And I think that we try and have this recipe of which, if we have a high-risk mare, we just throw them on all of this. And I think there's a lot of variation in what we see, and we need to treat for what we see, not necessarily what we think the mare has. And that way we, again, get back into better antimicrobial stewardship. So what are we going to do? We're going to start out with our ultrasound examination, and I always do my transrectal ultrasound exam the same way. You got to get used to doing it. That's how you know what's normal to you, when something is abnormal. And so when I always go in, I will go ahead and find the fetus, and then I come back and I look at the fluid cavities. We have the amniotic fluid, we have the amnion, we have the allantoic space, and then we come back and see the combined uteroplacental thickness there. We're then able to work our way up towards the cervical star region where the cervix is, and then we're able to move caudally along the cervix to see how closed it is. And it's good that this is actually going so slowly so you can see what is actually happening. Once I can see that that cervix is closed or open, I go back then to my placenta. Here you can see a little cyst. Go back to my combined uteroplacental thickness and I'll measure it. And Catherine Rinalden and co-workers did a really nice study looking at the normal thickness of the placenta and the uterus. And when we usually take this measurement, it's about an inch lower below the internal os. We want to make sure that we have our vessel ventrally and that we try and get a consistent thickness, because just by rotating the probe, you can change that thickness dramatically. So we want to make sure we have the internal os of the cervix and we have our vessel and we're getting 2 measurements. And I will usually average the 2 measurements. And if you're consistent, you will find those 2 measurements to be pretty close in accuracy. This is just a chart of what they came up with normal. I have a little bit of a cheat sheet in my mind in that I will accept basically 0.1 centimeters less than the month. So if I know that this mare is 9 months of gestation, I would like her combined thickness to be 0.8 or less, 0.8 centimeters or less, okay? 7 months, 0.6 centimeters or less. It's just kind of an easy range of which I can remember. So what else can we look at? Well, there are variations of normal, and I found in mares that sometimes we will find mares that have folds. It's also very important when you're doing combined thickness that you don't include the amnion. The amnion will be floating freely in that fluid, and so we need to be careful that we don't think that it's separation. Here it is again. And that it's actually the amnion, and we don't include it in our combined thickness. Here you can see some folds in which we want to make sure that when we do our calculation, we're not going from the top of the fold all the way to the bottom. We want to make sure that we're just incorporating the fold, which is A to A and B to B. And you'll see that those are relatively close in thickness. The other thing we want to do is we want to make sure that what we're identifying as separation of the placenta from the uterus is actually separation, not just blood vessels, or edema is actually edema, not just blood vessels. And so here you can see, using color flow, is you can see the vessels, and we don't want to call this edema or separation, or this, and we have vasculature there. So making sure that what we're seeing is actually what we think we're seeing is obviously what we want to do. Going back to the cervix, it's important to identify whether the cervix is open, because as we said with ascending infection, that's how the bacteria is going to get into the uterus. And so we see here, in this, it's the internal os, and we know that the internal os has have folds, so that the placenta can't actually attach to those folds, so that there'll be a little area right at that internal os that it may not be completely adjacent to it, and that's why you have the cervical star on your placenta when you see a red bag. That's where the internal os attaches. And so when we look on ultrasound, we can see opening to the cervix, which you can see here is just black, which is a clear fluid, as opposed to this one, which we have more cellular fluid. And this is the one that I'm going to be a little bit more concerned about having inflammation and potentially infection there. Another thing we want to look at is for edema to our placenta, and here we have the uterus that's actually edematous. We have the placenta that's edematous, and here the placenta, and we'll usually see an increased combined thickness with edema. Now, is edema necessarily meaning infection? Is it just inflammation? Is it just vascular compromise? And that's where we have to put our whole picture together, because how we treat that mare and how we monitor that mare is going to be determined on what we find. And so a lot of times if I see edema, and here's a video of a mare with severe edema, up here, if I see this severe, I'm definitely going to be worried. But a little bit of edema, we don't know at certain stages of gestation if placentas become a little compromised vascularly, and that's why they become edematous. But if you come back a week later, a lot of times the edema will have subsided and they'll go back to normal. Sometimes if she's a valuable mare, or if we're worried about previous pathology, we can put them on different medications and then come back and recheck. I think the key is recognizing that it's a very fluid process, and that just because you have something today, it doesn't mean that it will be there tomorrow. Here we have placental separation. We have our open cervix with a little bit of placental separation there, and here obviously a lot more placental separation at the cervical star region. And here we have our cervix, which you can see is open, and then we come down and we can see some separation here at the cervical star, extending a little further down. Now all of these mares that I'm showing you have actually, except for the one with the severe edema, she actually came in presenting as a hydrops, which ended up not being a hydrops. But all of these mares were actually what we call subclinical changes, in that they had no outwardly premature mammary gland development, they had no vaginal discharge. This was just what we were finding on monitoring in order to try and find things early so that we could potentially head things off before we had an abortion. So here we can look at fetal fluids, we can look at the amniotic fluid, we can look at the allantoic fluid, we can look at hyperechogenicity or echogenicity in quantity. And then we go to our transabdominal ultrasonography. And here we can look at our Combined uteroplacental thickness again. We want to look for separation. We want to look for folds. This, in fact, is a fold as opposed to separation, and when you look at it, you could actually see that there was, again, vessels there, and it was not, in fact, separation. I don't usually do a combined uteroplacental thickness transabdominally because I think it's not as accurate as transrectally, depending on how the fetus is laying, depending on what horn you're looking at. There's a lot of variation, but I do look at separation. I do look at edema. So those are all important things. Again, we can look at echogenicity and volume of the fetal fluids, especially if we want to diagnose hydrops allantois, if the mare is getting large. And then again, we can look for the umbilical cord. We can look at its size, blood flow. For me, I don't look at these as much, and usually if I find the umbilicus, I'm very concerned about it. So we also want to remember that premature mammary gland development can be a sign of twins, and so once we're there ultrasounding the mare, we don't want to just focus on the placenta. We want to make sure that she doesn't have twins. We can also look at fetal well-being, and there was a nice study done over the last couple years that took the 6 parameters that Virginia Reef from Penn had comprised into 3 parameters, which are a little easier to do in the field, in which you can look at fetal heart rate, aortic diameter, and CTUP, and these correlated well with fetal well-being and outcomes. The other thing that Steph Buca has looked at is looked at the intracranial blood flow impedance, looking at the middle cerebral artery. I have not tried to do this. I think it's probably very much a learning curve, and when I'm standing behind a mare, I need to not be learning it at that time. What I will use is I will use color Doppler in order to try and identify if that fetus is alive or if it's moving. A lot of times the fetus, when you go in and ultrasound them, may not move. You may not be able to identify the movement, and usually when you turn on the color Doppler, all of a sudden it wakes them up and they start moving, which is good. If they don't, you can find a vessel on the fetus and you can put the color Doppler on it, and you can usually see pulsing of the vessel to know that in fact the fetus is alive and potentially get a heart rate. The other thing that I think is some exciting things on the horizon is looking at hormones. I think that we've always in the past looked at progestogens and estrone sulfate. There are some new studies that we'll talk about in a minute that show potentially other avenues that we can go. But one thing we do need to recognize is that once the placenta takes over, we are no longer looking at progesterone in the mare serum. We're looking at progestogens, or the metabolites of progesterone. And so it's really important to know what cross-reactivity your labs have with which metabolites, because your levels are going to vary dramatically as to what's normal. And if you're measuring progesterones, once the placenta formed, they are automatically low. So low progesterone is normal. It's the progestogens that you need to look at. And a nice study out of Gluck by Barry Ball showed that different labs and different assays will, in fact, give you different readings depending on the cross-reactivity and depending on the metabolites that those assays run. Another interesting paper that just came out from Gluck was by Carly Fedorka, in which she looked at circulating biomarkers such as estradiol 17 beta and progestogens, as well as alpha fetoproteins in mares that have an ascending placentitis. And the interesting thing was that with mares with ascending placentitis, our progestogens went up, our estradiol 17 beta went down, our alpha fetoprotein went up, but a better way to look at it was the ratio between the estradiol 17 beta and the progestogens. And so this is something on the horizon that I think we need to look at. The same was very true with focal mucoid placentitis, looking at them. And so again, progesterone and estradiol 17 beta, if you're able to run that assay, is something to potentially look at it, as well as alpha fetoprotein. A lot of these newer tests, unfortunately, are still only available in research and laboratory settings, but hopefully they will become more available to us as practitioners and as farms in the future. Another biomarker that I wanted to talk to about is serum amyloid A, which is acute phase protein that you see in inflammation. A lot of this research was done on mares that had clinical placentitis, and they found that the SAAs did increase when they had premature mammary gland development or vaginal discharge. This is associated also with hormonal changes. However, when I've done a lot of my monitoring and find either the opening of the cervical star or some edema or separation in a localized area, this has not been very fruitful pulling SAAs. I think at that point it's a very local inflammation, and so you don't get that systemic response with the increase of the SAA. I think this diagram tells us a lot. Again, Carly Fedorka at University of Kentucky and her group has looked at all of the inflammatory markers. There are a lot of pro-inflammatory cytokines, a lot of anti-inflammatory cytokines, of which you basically need an immunology degree, which she has, to understand. But I like to look at the overall picture and see what we can take away to utilize in the field. And one of the things that she found was that interleukin-6 has been very helpful in trying to diagnose placentitis, or it's been a factor that is something that we should look at. So I think that estradiol 17 beta is something that we can look at, and I think that interleukin-6, as well as the ratio of the estradiol 17 beta and progestrogens, is something that we can potentially, hopefully, use more in the future. Carrying on from her studies, they looked at pregnancies with ascending placentitis, and here is the interleukin-6 that we mentioned. She looked at it in ascending placentitis and in mucoid placentitis and found similar results between the two, which is actually kind of encouraging because the mucoid placentitis has been a little elusive to us all with regards to how it gets there and how to identify it prematurely. Another study that they did was looking at nocardiform placentitis and trying to identify factors, and this was a couple years ago, in which we had an increased incidence, and for a change we were prepared. We had lots of people pulling bloods, submitting bloods, looking at all of these factors, and they found that it had interestingly had no effect on fertility of these mares. These mares that got nocardiform placentitis were able to clear the bacteria. It's not a very hardy bacteria, so it's easy to get rid of, and those mares had similar fertility rates as non-nocardiform mares. In addition, they did show that viability of the fetus was affected by the amount of placenta that was affected, which obviously then affects the nutrient and oxygenation and fetal growth of that fetus. I think one of the best things that came out, at least from a clinician's perspective, it was the fact that they found that prophylactic antimicrobials and alternatives throughout gestation did not decrease the risk of the disease or improve the neonatal outcome. And I think over the years with placentitis in general, we've started to say, okay, well, if we want to prevent this from happening, we're just going to blankly give these mares antibiotics 5 days out of a month or give them Regemate over the whole gestation. And this helps to show that that did not decrease the incidence or help fetal viability. So again, we need to think about not just having this one recipe for all our mares and looking at what we can treat what with depending on what we find. So what are our treatment options once we have identified these high-risk mares, or how are we going to manage them? Well, the ways we combat our problems will be, 1, to combat the infection, 2, to decrease the inflammation, because they've shown that it's actually the prostaglandin that is released with the inflammatory cytokines that causes the uterus to contract to expel the fetus. We can improve blood flow in order to help, 1, the edema and circulation, improve oxygenation and nutrients to the fetus, and then provide uteroquiescence and provide fetal support and growth. So starting with antibiotics, there are a few antibiotics that we know, looking at the research that's been done, that cross the placenta. One is penicillin, the other one is genicin. There are new studies that have shown that Equisol is a good option to cross the placenta, as opposed to trimethoprim sulfa, which actually studies are just haven't been done specifically for that, and we extrapolate it a little bit from the human side of things. Another antibiotic that I was glad to see Igor Kinesio look at is doxycycline. It's another oral antibiotic, and I think with these mares that have problems that we need to put them on long-term antibiotic. We certainly don't want to be injecting these mares with penicillin or genicin every day, and besides the Equisol, this is a good other alternative to doxycycline. I also will have mares that may not respond to one drug and that I may take off for 24, 48 hours and then potentially switch to another one. So it gives you a couple of options. Ultimately, the best thing to do would be, if you have a vaginal discharge, would be to culture that to identify what bacteria and the sensitivity that you're dealing with so that you're able to use the correct antibiotic to start off with. But I certainly wouldn't go transversing the cervix if it's not open or if there's not an exudate coming out. Another oral antibiotic that Igor Kinesio looked at was enrofloxacin, which then breaks down into ciprofloxacin, and I'm a little hesitant to take out my big guns. I think that the research he does showed that it crosses the placenta, but it's a very big gun, as well as the studies that they did not take it out to yearling status, so it's a little bit shorter in longevity, and so it's important to recognize that, one, there are other options that are not as big an antibiotic. We'd like to save those for really bad diseases, and then we don't know the long-term effects on these foals. With regard to anti-inflammatories, there have been a nice study from Margaret McPherson out of Florida showing firocoxib or Equiox in combination with alternogest and antimicrobials that has increased the outcome and fetal viability. I think that this is a great alternative to flunixin. Flunixin, again, is a great maybe initial high-gun anti-inflammatory, but you don't want to keep that mare on injectable flunixin for long periods of time. And so the firocoxib gives you another alternative to do orally, and a lot of mares live on them for their ailments in terms of arthritis, so putting a mare on this and keeping them on this is not such a bad thing. Other things that we can use to increase blood flow, increase malleability of the red blood cells, decrease platelet aggregation would be aspirin or acetylsalicylic acid, and the other one would be pentoxifylline. So again, another bit of arsenal in our box. This was a nice study that did show how aspirin affected the fetal placental development in mares. And then, of course, we get to our infamous altrinogest or progestin supplementation. And I think that the jury is still a little bit out. Do I use it? Yes. Do I want to stop the uterus from contracting? Yes. Do we know what effect it has on the immune system? Not in pregnancy yet. Again, University of Kentucky showed that it did affect it in estrus versus diestrus, supplementing with specifically altrinogest. So I think we need to look at the effects on the immune system, but when you say, do I want the uterus to contract or do I want the immune system, it's a little bit of a handoff there. So I still use it on my problem mares. I will admit that I'm afraid of the high-risk mare, but it depends on the stage of gestation that I may start using it, depending on when they've had issues, and it depends on the levels of progestogens that I have too. So I try and put everything together and not just pick one thing and not just have a recipe. Each mare is an individual, and each problem that they have can be treated independently. The other thing that's been in the literature is using estradiol cypionate. I think the Brazilians are very big on this. This study, which did show an increase in weight of foals born and viability, they only used 3 doses. It was very close to term when they infected the mares. So I think that the jury is still a little bit out. I like to be able to think things through in my mind physiologically, how it can work. The only thing that I can think of would be potentially if it improves blood flow to the fetus, because estrogen causes vasodilation, and so maybe that's potentially a mechanism. Could we do it with aspirin or pentoxifylline? Probably. Again, this has not been duly looked into, I'd say clinically yet. I think for mares that you have to have for them on it for a long duration of time. Are they going to run when you come with the needle? Probably. So again, you have to weigh the pros and cons. Would it be something that I would try in that very expensive mare that has terrible problems that nothing else is working? Probably. Okay, so we need to look at fetal viability, and a lot of times where this comes into play is with fescue toxicosis. We do see a lot of that, especially this year. We've had a lot of placental edema and premature placental separation. I think we've had very little coal dying off of our grass, so that our fescue has been there increased amount and longer, and so we've seen some of these issues. And so domperidone is one dopamine antagonist that we can use to try and help with fetal viability. I also will potentially use this in mares that go over. I always believe that I'm not big in inducing mares at all. I very rarely, if ever, do. I think that if they have gone for long gestational range or period, it's because that baby needs to cook in the oven. It needs to grow a little bit more, it needs to develop a little bit more. There's a reason why it's in there, and so I usually let them cook. And most of the time they come out, and we're glad that we did leave them cook. One thing I am concerned about is there compromise to that baby? Is there compromise to that uterus? And that's why you have this increased gestational length. Well, obviously the uterus may not be functioning very well, but there was a study that did show that giving mares domperidone did improve fetal viability in the long run. So that is something that I will think about, even if they have mammary gland development, and I don't think it's fescue. If they go longer, at least a week or two over their supposed gestational length, I will think about putting them on domperidone. Vitamin E has neurological effects on the fetus, so potentially if I'm concerned about perfusion or oxygenation of that fetus, I may put the mare on that. We can give oxygen supplementation to the mare. If she's compromised and they come in, obviously it will increase the fetal oxygenation. And then hyperbaric chambers, I think, are something that we need to look further into. I have used it on placentitis mares, at high-risk mares that we're worried about potential outcomes to try and improve the oxygenation to the fetus. I think the biggest question that always is asked to me is, how long do you leave your mares on treatment? I think that this is, again, where monitoring comes into play, seeing the response of your treatment. Potentially, if you have an elevated SAA and you have a clinical placentitis, looking at SAAs, seeing when they come back down, maybe that's going to be helpful in knowing that your treatment is working. They did a nice study at University of Florida that showed that even mares on antibiotics and on treatment, even when they fold, they could still culture bacteria. So do we really just hold it at bay? Do we get rid of it? I think it's a lot up to the clinician and management judgment there as to whether they want to continue or take it off. I tend to be one that if I'm going to put a mare on antibiotics, I have to have a good reason to, and then I will usually keep them on antibiotics for the duration. So, in conclusion, we want to identify our high-risk mares. We want to ultrasound our screening monthly, 7, 8, 9. Now, I will, if I'm concerned about something and I decide not to treat as abnormal, I'll come back a week later and I'll see if there are any changes, if they've gotten worse. Sometimes when you have an open cervix, I'll put them on altrinogest to try and close it down so we don't get bacteria getting into the uterus, and but I may come back in a week or 2 weeks and see if the opening's gotten worse, see if we have any fluid there, what kind of fluid it is, if it's cellular, if it's acellular. So all of those observations go into how I'm going to treat this mare and how I'm going to progressively treat her. We want to treat the abnormalities. We want to monitor them continuously so that we see our response. We don't see our response, we're able to amend our treatment as necessary. And then we want to continue to assess our fetal viability, because the worst thing is for a fetus to be compromised and be non-viable, and then that mare sits there because we have her on all these drugs and we have her on altrinogest and she doesn't get rid of it herself. So I want to thank everybody for enduring the day and welcome any questions, and thank you for having me.